Amanda has sent in an observation or a question, so thinking about skeletal maturation. She asks what the implications are for high velocity techniques, manipulation in patients under 25. She says she'd always be cautious and personally wouldn't do it with younger patients, particularly under 18, but she'd never have thought that any caution should be extended into the 20s. That sounds wrong. Not that she wouldn't extend any caution into the 20s, but it wouldn't have been one of the factors that she'd be taking into account.
Yeah, absolutely. And it's a really good point. So I think this is where one of the issues occurs is if we are thinking about at least 1 in 2 of these children, I think maybe go back to some of the research to highlight the point is that when a group of young people presented to a doctor in America with just a 2-week history of low back pain, because in the USA, MRI scanning is a lot more prevalent, and much more accessible. These kids were all imaged, so a 2-week history of low back pain. And what happened was that 48% of them on X-ray had a spondylolysis, and that's effectively a term that's used to describe a lumbar stress fracture in those grade 3, grade 4 bone stress injuries. So at this point, it gives a real sort of question to why would we be doing any kind of hands-on intervention to these kids who have a potential stress fracture. So when we've got this classic history of youth athlete, they're involved in extension-based sports, and we know that the preponderance of them will probably have an element of bone stress injury, be that bone edema or a lumbar stress fracture. So at this point, I guess my threshold for using manual techniques, and I'm trained in high velocity techniques, would be really low until I was confident that that person had gone through skeletal maturation. And the area that we associate with those bone stress injuries is the pars interarticularis, and the ossification age, give or take a couple of years either side, depending on whether they're early developers or late, is going to be around the age of 23, 24. So I guess what we need to start with is we know that the anatomy is going to be that of immature bone. We know that the likely diagnosis in this specific cohort with this specific history is going to be a potential for any level, we don't know until we scan them, any level of bone stress injury, and that may include a fracture. And I think whilst I personally believe that we are unlikely to cause a fracture, we may worsen one. And the problem we've got is even if that's not likely, then I've just had a case quite recently where a child presented to me with, excuse me, with a 6-month history of low back pain. And because of the symptoms, they started with that classic single-sided, they moved to being bilateral, they moved to becoming constant. I was quite concerned that the child not only had a bone stress injury, but probably quite a severe one at this point. So we got some imaging done, and there are a stress fracture at L4 and a bilateral stress fracture at L5. Now, this child was manipulated at the onset of the condition, and the parents are now very anxious. There's a potential for litigation going on. And how do we defend our actions in terms of, I actually don't think that the manipulation probably had anything to do with the onset of the condition. Neither do I think it had anything to do with how it progressed. But I really struggle to defend that person in court. And that's where sometimes we have to make our decisions by, is this something that we can actually justify given the anatomy, the maturation, and the likely disease progression?